What is DM?
So can I try?
Yes, please.
Okay, what I know, diabetes mellitus is a condition where characterized by high glucose levels. It can be classified as either type 1 or type 2. Yes.
Okay, good. Thank you. Then any other person? Any other person?
In diabetes mellitus, like where there's a problem with high blood sugar, there can be a problem with insensitivity to insulin, or the body is not making enough insulin.
Okay, exactly. So you told us about the pathogenesis of the condition. Okay, good. So how many of you normally came across a patient with diabetes? So I think majority of you most likely, because it is a most common condition. Okay, so toward the end, we'll see like this video as a summary, but let us proceed. So what is the objectives of this session? So at the end of this session, you should be able to differentiate like the different types of DM, like the type 1, type 2, and gestational DM. Then you should be able to list the screening and the diagnostic criteria for DM and identify the treatment modalities of DM and identify the various complications of DM and its management. But those are like the major pointers or the major objectives we are going to discuss at the end of like this type of endocrine disorder, like clinical features, diagnostic criteria, then treatment modalities and complication, and as well as it is management. So DM is a heterogeneous group of metabolic disorder. It's actually one of the metabolic disorder that it is not only like a single entity characterized by hyperglycemia, but as a result of insulin resistance and deficiency, the patient will encounter having several complications or several even metabolic disorder can happen. So mainly it is associated with abnormal metabolism in carbohydrate, fat, and protein metabolism. So those are the major issues when a patient is having DM. So you will see a problem in carbohydrate metabolism. So the patient will end up having hyperglycemia. But remember the risk of high sugar level. The moment the sugar is high, it can actually increase the risk of several complications such as retinopathy. So the patient can have a loss of vision, then nephropathy. High sugar level can actually cause destruction of the glomerulus of the kidney, so it can cause diabetic nephropathy, and it can actually even can cause damage of the peripheral system, like nephropathy. Then this actually ultimately causes even amputation. So the patient is really having, that is why sugar is really very bad. Yeah, when it is high, it is actually having a lot of macro and macrovascular complication we'll see in the course of this topic. Then, what is the effect on the fat metabolism? So remember, when there is no insulin, or when there is deficiency of insulin, and when a person is having, or when the target tissue is insensitive to insulin, the action of insulin, what will happen? Like the body will be starved because they cannot use glucose. Like majority of the tissues, like the muscle and adipose tissues, they cannot use glucose without insulin. So because of that reason, they will be starved. And as a result, the body tries to use compensatory mechanism to use an alternative source of energy. That is why degradation of fat and protein metabolism will be happened. So like this is just an alternative source when the carbohydrate is not possible to use, now the fat and the protein will continue to degrade, and the patient will end up several complications. So as a result of fat degradation, like the patient will end up having even like ketoacidosis, like the patient can have even metabolic acidosis because of ketone body accumulation. Then protein metabolism can cause even muscle wasting and weight loss, which is very common in type 1 DM. So you can actually even imagine like why, or that is why DM is a heterogeneous group of metabolic disorder. Okay, good. Then, as I mentioned before, it has actually several long-term and macrovascular complications. We'll discuss like the microvascular complication and the macrovascular complications of DM. Then, apart from that, this complication can contribute to a leading cause of new onset of blindness among adults. I don't know whether you came across like a patient who become blind or maybe having visual problem as a result of DM. Because the problem with sugar, when the sugar is actually high in the retina, it can actually convert it to like a sorbitol, which is osmotic type of, it's just like, it has osmotic effect and it can cause osmotic damage. So that is a major problem. In the eye, it causes osmotic damage of the retina and the patient can end up having loss of vision. That is why frequent visual examination is very, very essential, just like as a key part of the monitoring when a patient is having high sugar level. Then the other type is it can cause end-stage renal disease. If you remember what we have discussed in the previous semester in CKD, the most leading type of cause, or the most leading cause of end-stage renal disease is sugar. That is why sugar control is very, very important. Then apart from that, it can cause non-traumatic lower limb amputation. I don't know whether you have heard about like a patient with DM who developed gangrene later on the life. So this is because of like high sugar can cause damage of the like the peripheral nerves. So that damage can actually even cause decrease, or it just actually decrease blood flow to the lower extremities, and the major cause of like dry gangrene. So dry gangrene is really very, very common. So when some part of the body is actually deprived from oxygen and nutrients, it becomes gangrenous and necrotic. So the only treatment modalities we can have at that point is just like amputation. So that is why it is one of the major cause of non-traumatic lower limb amputation. So you can actually even imagine how DM is very complex metabolic disorder, and it requires like adequate sugar control. Then when you look at the typical features of DM, it can be characterized by either a complete lack of insulin or a relative lack of insulin, which is very common in type 2 DM, or it could be an insulin resistance. So when you say insulin resistance, like the body is actually having sufficient level of insulin, but the target tissues are not responding to the action of insulin. So especially the major cause of, according to the current evidence, the major cause of insulin resistance is obesity. So like if you are actually obese, I advise you, or I encourage you, you have to do dietary modification. That is very, very, very key and essential. Otherwise, later in your life, the probability of developing DM is very, very high. So even with the current era of COVID, I don't know whether you have heard about like the major risk of death in COVID patients is actually DM comorbidity. You can actually even see like the systematic review was actually reported like the major cause of death in COVID patients at the moment is like having DM comorbidity. So there are other comorbidities that are responsible, even hypertension, but DM is the leading cause of death in COVID patients. Even the systematic review we did recently with our colleagues normal even showed the days is actually very high in diabetic patients. Okay, fine. I think by the much sure you read about the COVID management. So nowadays, even it should be actually included when someone is teaching on infectious disease. They're supposed to include about the COVID management. Okay, then that is why insulin resistance is really an issue, especially in type 2 DM. So what will happen when a patient is actually lacking insulin, or when the target tissue is resistant to the action of insulin? So as a result, what will happen, especially the insulin-dependent organs, like the muscle and adipose tissues, they cannot use glucose as a source of energy. But of course, brain entirely depend on the blood sugar level. But when the sugar level is actually very low, that is why, that is the only source of energy that the brain cell can get. So when a patient is having hypoglycemia, the probability of death is very high because the brain tissue is not getting energy because of inadequacy of glucose in the serum. However, brain cell will not depend on insulin to get or to use glucose as a source of energy. So it is just like working independent of insulin. However, like the muscle and the adipose tissues and some other organ, they entirely depend on insulin. So they take insulin, when they are a transporter, by the way. Yeah? When there is an insulin will take the sugar here, then to the organ, so that those organs, they normally undergo glycolysis, what you have covered in biochemistry, and they actually even undergo, the metabolic product of glycolysis undergo the Krebs cycle, then it will actually generate energy to be utilized as a source of energy. So that is why when a patient is having this defect and they cannot use glucose as a source of energy. Okay, when you look at the classifications of the blood sugar level, this is the summary, and even this is the current diagnostic tests, what we can do to classify whether the patient is having DM or not. So you can actually even say FPG means fasting plasma glucose level. This one is glycated hemoglobin, hemoglobin A1C, and OGTT means oral glucose tolerance test. I hope, I don't know whether you have covered it in clinical chemistry about those tests, and have you done any practical, maybe in mice? In mice model is just in the pharmacology counterpart. So did you manage to, have you done any experiment about the oral glucose tolerance test in the clinical chemistry? Because you have covered the clinical chemistry part before the closure of the school.
No.
Oh, you have not done, huh?
No.
Okay, fine. So anyway, those are the most common tests, by the way. And even if someone is interested to do a research, anti-diabetic activity of a certain medicinal plants in mice model, those are the tests you are going to use. The fasting blood sugar level and OGTT. Hemoglobin A1C, I have never seen when they are doing in there. It's very, even cost-wise, I think it's expensive. So most likely this one, fasting, and what you need is just only the glucometer, yeah, and the strip, yeah. So that is how even in mice model, experiment can be done. You make the mice diabetic. You give them actually a chemical known as streptozotocin. That can actually permanently distract the pancreatic cell, so the mice become diabetic. Once you make the mice diabetic, now you give your experimental plant with different doses and see how the sugar control has been done. after induction. Okay, so maybe some of you can think, maybe you can do. Okay, getting the reagent to kill the mice to cause the mice diabetic might not be very easy, but at least you can do this. OGTT, you just you load glucose, then after that you can actually even see the effect. Okay, so when you say the fasting blood sugar level means the patient does not have any calorie intake for a minimum of 8 hours. Like before 8 hours, if you don't restrict calorie for 8 hours, the probability of having false result is very high. So the patient is supposed to be deprived from taking any food, but they can drink water because water does not have calorie. They can drink water, but they are not allowed to take food. A minimum of 8 hours, then you measure the blood sugar level. That is known as the fasting plasma glucose level. So the normal is usually, as I mentioned even in the previous lesson, is even the case discussion, the normal value is usually between 70 to 100. So it is generally less than 100 milligram per deciliter. In terms of millimole, it is 5.6. But remember, the most common unit of measurement for glucose in Kenya is a millimole. But in our country, they usually use milligram per deciliter. That's why I just included both. Then hemoglobin A1C. What is glycated hemoglobin? You have not mentioned elsewhere, maybe in the clinical chemistry, but I was wondering how they pass like this very important point. What is glycated hemoglobin? Now it is too early, so maybe some of you might sleep because we don't see. Anyone who can try?
Is it hemoglobin which has glucose attached to it?
Yes, exactly. So normally it is just like the percentage of hemoglobin that is attached to glucose. When the sugar level is actually very high, so it binds with the hemoglobin. So we call it glycated hemoglobin. And the normal value is usually less than 5.6%. If it is between 5.7 to 6%, 6.4, we call it impaired. That is actually, we call it even pre-diabetics. But if it is greater than 6.5%, we can say the patient is actually diabetes. So anyways, in terms of fasting blood sugar level, the pre-diabetic level is between 100 to 125, or that is between 5.6 to 6.9 millimole. When you say diabetic, when the sugar level or the fasting sugar level is above 126, 126, that is, this is in milligram per deciliter and 7.0 in millimole. So this is how the blood sugar classification look like. Or GTT, this is oral glucose tolerance test. That means you give 75 or 100 milligram of, sorry, it is just gram, 75 or 100 gram of sugar, then you measure the sugar level. So if it is normal, it is like less than 140. If it is in the pre-diabetic, it is between 140 to 199. In diabetics, it is just like above 200. So remember, if a patient is actually having diabetic, and if you load glucose, means they cannot actually utilize glucose. That is why the sugar level is actually very high. So this is diagnostic along with the clinical feature. But remember, the fasting blood sugar level and the hemoglobin A1C is usually the preferred over OGTT because the OGTT is usually cumbersome. It just load glucose, then you weigh every hour, every 2 hours, every 4 hours. So the measurement is really like a kind of cumbersome. But this one is just you take a sample, just like sample, you fast or glycated, even you don't drink, even you are not supposed to fast. just actually measure, because the glycated hemoglobin will tell us how is the sugar level control in the past 3 months. So it will give you an idea how is the sugar level in the past 3 months. But if you want to solve, sorry, any question? Okay. So if you want to know what is the sugar level today, you have to do either OGTT, random sugar level, or fasting blood sugar level. That is how you are going to assess the current sugar level. But if you want to know how is the control in the past 3 months or prevent sugar level, do glycated hemoglobin, A1C. But this one is, I think, expensive, cost-wise, the test is expensive. Okay, so this is how the normal and diabetic plasma glucose level look like. Then let us see the classification of DM. So as I mentioned at the beginning of the session, DM classifications are broadly classified into 3 categories: type 1, type 2, and gestational DM. So what is type 1 DM? Type 1 DM is also known as insulin dependent or juvenile onset. So why it is called insulin dependent? Maybe is there anyone who can try? Why type 1 DM is known as insulin dependent? Face Okello, can you try? Because we're waiting.
I think because there is destruction of the beta cells of the pancreas, therefore, the body is not able to utilize the insulin.
Okay, good. So it is in relation to like the insulin destruction. So even the treatment, like because of absolute destruction of insulin or beta cells of the pancreas, so the patient is usually deficient of insulin. So that is why the patient is usually depending on insulin, even when you are treating those conditions. That is why it is known as insulin dependent. So this condition is very common in young adults, like less than 30 years old. So by the way, I will come later how we are going to differentiate between type 1 and type 2 DM clinically. So mostly type 1 DM is very common in adolescents and children. I don't know whether you came across a type 1 patient in children. It's very, very common. It's very, very common condition. And I will actually later tell you why it is common in children. So what really causes type 1 DM is mostly autoimmune condition. So the exact etiology is not really known, but what really causes, or based on the evidence, based on the guideline, they are saying mostly it is results from autoimmune destruction of the beta cells of the pancreas, and this ultimately causes insulin deficiency. That is why when a patient is having any autoimmune disease, the probability of having DM is very, very high, by the way, because the autoimmune or the antibodies can actually even affect the beta cells of the pancreas, and the patient will end up having type 1 DM. Okay, then younger individuals typically have a more rapid rate of B-cell destruction and often present with ketoacidosis. So it is actually, in terms of even onset of action, it is actually like very, very fast. It can occur as a sudden, but the clinical presentation will take, comparatively, it is just actually occur as a sudden as compared to type 2 DM. Then the major problem with type 1 DM is the probability of ketoacidosis. You can actually even hear, we are discussing about the complications of DM. DKA, diabetic ketoacidosis, is a medical emergency. If you don't treat DKA very well, the patient will die definitely mostly because of acidotic condition and dehydration. Yeah, because of dehydration, most patients with DKA will die. The sugar level is significantly elevated, so they will die. That is a major problem. That is why DKA is a medical emergency. But I will let you know, or we shall discuss later why DKA is very common in type 1 DM, but not in type 2 DM. Okay. So it is usually diagnosed in children, as I mentioned before, in adults younger than 30 years of age. But that is just like based on epidemiological studies, but it can present at any age. But it is very, very unlikely to see in adults. Much less common than type 2 DM. So fortunately, type 1 DM, the prevalence is actually is very low. Maybe some of you might be interested to do some kind of research as part of your project next year. Like you can actually even look at type 2 DM management, or maybe you can see any complication associated with type 1 DM. You can see, but retrospectively, not like prospectively, because the number of patients are very, very few. So much less common than type 2 DM. It accounts, by the way, 5 to 10% of all diagnosed cases of DM. Then when you look at the manifestation, it's usually manifested by hyperglycemia. Why hyperglycemia? Because the sugar is not utilized because like the insulin is deficient. Remember insulin, I will come later, by the way, the physiological role of insulin. Insulin normally promote utilization of glucose so that they can use as energy source. Then if there is an excess, it can be stored in the form of fats and even the form of glycogen. So that is why insulin is very, very important, a hormone to create sugar level in the body system. But if you administer excessive dose of insulin to a patient, you can kill the patient. It can actually even cause perfect death because of hypoglycemic shock. You just deprive the sugar level in the serum. So if you reduce sugar level means in the serum means you are reducing the energy source to the brain, and the brain tissue will die. So when you say the patient is dying, when the brain tissue starts to die, we can say the patient is dying. I don't know whether you came across when the patient is dying, because you have never gone to the ward, you might not encounter several times, but we have encountered several times in the ward. Yeah. Okay, manifested by hyperglycemia, then breakdown of body fats, protein, and development of ketosis. So remember, if the sugar is the primary source, if the carbohydrate is not used, now what will happen? The cell will actually start to use alternative source of energy. So fats will undergo breakdown. So ultimately, even the free fatty acid that is released by breakdown of fat, they can actually be converted to ketone bodies so that they increase what? Increase risk of ketosis that ultimately causes acidosis. Then protein degradation will continue because the amino acids can be used in the production of glucose, synthesis of glucose. So that is why protein degradation will be. As a result of the protein degradation, the patient encounter muscle wasting. So those are the typical features. A breakdown of fat, protein, and ketosis in hyperglycemia is very common in type 1 DM. So type 1, which is the most prevalent and accounts like 92 and 5% of the cases in the practice. So it is previously known as adult onset and non-insulin dependent DM. Here, the problem is not insulin deficiency. Even you measure the serum level of insulin, but mostly not done. Mostly you don't measure the insulin level. So the current lab tests we're having, is just like to look the sugar level. So there is no way to measure insulin level in the serum in the African setting, as far as I know. So why it is called non-insulin dependent? Because the problem here, the insulin level is adequate or sufficient, but can be even normal. However, the target tissues are not responding. So there is an insulin resistance. So that is, we call it insulin independent type of DM. Then in terms of genetic inheritance, it is actually very stronger. That is why when you take family history of a DM type 2 DM patient, we need to ask whether they do have first degree or second degree relatives of type 2 DM, because the genetic predisposition component is comparatively high as compared to type 2 DM, and very common in adults and usually occur as we age. The prevalence increases as we age. That is why if we're actually becoming above 45 years of age, screening every year or every you have to start screening. This is like the recommendation according to the American Diabetic Association. So the moment you are becoming above 40, at least you have to do screen for DM. Then after that, you can do actually the checkup every 3 years. So that is the recommendation, because as we age, where actually increased weight gain is very common. Then in case, especially if the person is not really regularly exercising, the probability of having DM is very, very high as we age. Okay, that is why it is very common above the age of 40. By the way, if you see, type 2 DM is very common above the age of 30. Some literature says 35, but most literature normally recommend like type 2 DM is very prevalent after the age of 40. So as I mentioned before, it is characterized by relative insulin deficiency or insulin resistance. It could be either relative or deficiency or insulin resistance. But type 1 DM is an absolute deficiency of insulin. So relative insulin deficiency means like the patient is having a small proportion of insulin. That is why the complications of type 2 DM is not as such as compared to type 1 DM. Even when you look at even the level of hyperglycemia, it is very high in type 1 as compared to type 2 DM. So this is one major difference, and it is usually slow and progressive in its development and often preceded by pre-diabetes. But that is why I think this time round there is nowhere to be skipped like the sugar level, because if someone usually goes to like the clinic or a private sector, mostly they check the sugar level. Like this time around, it's just like a common practice, especially in the nursing triage. It's just like a common practice to check sugar level as part of like the screening. Okay, then, and mostly it starts like having pre-diabetic. And I mentioned when the sugar level is between 100 to 125 milligram per deciliter, this is fasting. This is when we call impaired blood glucose level or pre-diabetes. So in the pre-diabetes level, it is defined as having either a fasting or postprandial blood glucose level higher than normal, but not high enough to be classified as DM. They are not classified as DM, but the sugar is high as compared to the normal individual. So, but they are at high risk of developing type 2 DM. So in case if the patient become pre-diabetic during the screening, the usual recommendation is lifestyle modification. So the doctor most likely will advise the patient to do regular exercise, because as you exercise, you can actually even promote the sensitivity of the target organ to the action of insulin. That is why regular exercise is very, very important. But let me ask you a question. How frequent do you exercise? Or you are just like sitting the whole day? How frequent normally do you exercise? Just tell us your life experience.
Around 40 minutes a day, 3 to 4 times a week.
Oh, so you do it regularly?
Yes.
Oh, good. Any other person? There is no athlete from this class? Maybe Geoffrey?
Annette.
So I don't exercise.
Okay, okay. Then any other person? Angela, you want to tell us something?
So I also don't exercise.
Okay. Jerry?
I just tried running every morning for like 3 times a week.
Oh, 3 times a week?
Yeah.
Okay, good. Because if you actually like walk around Nairobi, like especially around the road, you will see so many people are actually running, especially on Sunday. Yeah. So anyways, exercise is like the best modality of treatment to rescue from cardiovascular disorders. Hypertension, it ranges from DM up to even stroke. So that is why, if you see, by the way, like those people who is actually doing regular exercise throughout their lifetime, they will even live longer and they don't have any risk of cardiovascular complication. So that is why exercise is really like, it's just like like routine day-to-day activities. It's supposed to be like that. Instead of actually like taking a lot of medication later in your life, you have to start exercising and burn like excess calories, what you have. That is very, very important. Okay, then. So that is why when a patient is having pre-diabetes, mostly we don't start treatment, but what the recommendation is lifestyle modification. Maybe the doctor will advise to reduce the consumption of sugar, like carbohydrate diet, then regular exercise. That is very important because exercise increases sensitivity of insulin to the target tissues. That is why it is usually recommended. Okay, then, how do we differentiate type 1 DM from type 2 DM? Maybe we shall have a discussion like sorry. What do you think about how do we differentiate type 1 DM from type 2 DM? Do we have any test that can tell us this patient is having type 2 DM or this patient is having type 2 DM? What do you think? You know, it is a very good question and you have to know.
I think the age can be used.
Okay, age, yes. Yeah, age is like the major factor that can be used in the practical setting, in the clinical setting. Any other?
I'm not sure, but I think maybe checking insulin levels, because maybe type 2 will be normal insulin, but they're insensitive to insulin.
Yeah, okay, good observation, but so far, there is no, I don't know, I think whether there is no way to measure the insulin level in the serum, or I don't know, but it is not like part of, because there is no any facility that can then the level of insulin in the serum. That is as far as I know, like even if you Google, even from the literature, there is no facility or there is no like standard procedure that measure level of insulin in the serum. Any other?
What about the antibodies? Because you said type 1 is caused by an autoimmune destruction.
Yes, antibody test. Antibody test can work, by the way, but I don't know how frequent it is usually done. But mostly they rely on the age of the patient. Okay, but antibody test will be another option because it is very likely if a patient is having autoimmune antibodies positive, most likely the patient will have type 1 DM. What about in terms of clinical presentation? What about in terms of clinical presentation? Because it will give us a clue whether the patient is having type 1 or type 2 DM.
Sam, can you say that most type 2 patients with type 2 diabetes are overweight, I think, then type 1, they just look normal. Yeah.
Okay, good observation. Any other?
You differentiate the family history.
Okay, family history, yes, because like
of it being genetic.
Exactly, type 2 DM is more of genetic, but type 1 is mostly because of autoimmune destruction. The issue of genetic component is very minimal. But as Annette said, we can actually look at the weight of the patient. So mostly, if you see type 2 DM, by the like more than 80% of type 2 DM is caused by obesity because obesity promotes insulin resistance, so it increases the risk of type 2 DM. So when you look at the patient physically, but mostly you have to do the body mass index, mostly they are obese type 2 patient. But when you look at type 1 patient, they do have an absolute deficiency of insulin. As a result of absolute deficiency of insulin, what will happen? The fat undergo degradation or catabolism, and the protein also undergo catabolism, and there is wasting. And mostly type 1 DM patients are very, very lean. So that is one way to see whether the patient is actually having type 1 or type 2 DM. So, and when we look at as a result of catabolism of fat, we call it lipolysis, the patient will develop ketone bodies. So mostly high level of ketone bodies in the urine as well as in the serum sample is usually very common in type 1 DM, but not in type 2 DM. By the way, it is very unlikely to see ketone bodies in type 2 diabetic patients unless they are actually severely ill. Why? Because remember, they do have relative insulin deficiency. So they do have a small amount of it. And the problem is like insulin resistance. So that insulin or the available insulin will prevent degradation of lipids. Because of that reason, it is very unlikely for those patients to have diabetic ketoacidosis. So that is why even in the practice areas, most DKA patients are either seriously uncontrolled type 2 diabetic patients and the most of the cases are usually type 1 DM. That is why you'll see type 1 DM patients, if they don't take insulin injection properly, at some point in time, they will encounter actually diabetic ketoacidosis. So those are the parameters, but mostly in our setting, they usually use the clinical picture to differentiate type 1 DM from type 2 DM, and they are mainly basing on the age of the patient. So if the patient is usually above the age of 40, it's just type 2. But there is a possibility of misdiagnosis because they are not using any lab parameter. But those are the parameter we are going to look at to differentiate whether the patient is having type 1 or type 2 DEM. That is actual practice. But the easiest way to differentiate between type 1 and type 2 DM is by measuring the C-peptide level. Remember, insulin is actually made up of 51 amino acids. Like I think the 21 is A chain and the 30 is the B chain. It has actually A and B chain. So, and insulin is usually synthesized in the form of prohormone, proinsulin. So when it undergoes cleavage, and this prohormone is actually bounded by the C-peptide or just by peptide bond. So when proinsulin is converted to insulin, the product will be insulin plus C-peptide. So when a patient is having a type 1 DM, that is an absolute deficiency, so the proinsulin conversion or the level of C-peptide is usually very low because the pancreas cell will not actually, is just distracted. So there is no generation of C-peptide. So in type 1 DM, C-peptide level is usually less than 1 nanogram per ml. However, if a patient is having type 2 DM, the proinsulin level is okay, and it can be converted to insulin and C-peptide. So because that conversion is already available because of insulin resistance, the C-peptide level is usually above 1 nanogram per ml. So when the C-peptide level is 1 nanogram per ml, it will tell us the patient is having type 2 DM because they are producing the C-peptide after cleavage endogenously. And if the level is very low, means like there is an absolute deficiency. So this is the easiest way, but unfortunately, there is no facility that will actually measure the C-peptide level in the African setting. So that is why mostly they are basing on the clinical picture and the age of the patient. So maybe you can explore more if there is any recent evidence or any recent evidence or better way of differentiating type 1 and type 2 DM. But the background information, this is sufficient for this level. Then this is all about type 1 and type 2 DM. Then in the next few minutes, let us talk about type 2, gestational DM. Sorry. Have you encountered any patient who developed DM during gestation period? Did anyone who came across? Anyone who came across? Okay, fine. So when you say gestational DM, it is defined as a glucose intolerance which is first recognized during pregnancy. So like if a patient is having high sugar level before pregnancy, that one is just, we call it is not related to pregnancy. But when the sugar level is high, or when the patient is having DM as a result of pregnancy, we call it gestational DM. So what really causes high sugar level during gestation? Mostly it is due to the hormonal changes as a result of pregnancy. So in the prenatal care, there is sugar measurement is like a routine apart from looking any gestational hypertension. So that is like one of the frequent monitoring that should usually be done by the gynecologist. So in most cases, The glucose intolerance usually first appear toward the beginning of the third trimester. So it is very unlikely to see the first and second trimester, but mostly it usually appear at the beginning of the third trimester of pregnancy. However, this gestational DM can be resolved after delivery. If you remember even what we have discussed in the hypertension, gestational hypertension, preeclampsia and eclampsia, the best treatment modality or definitive treatment is lever. After delivery, the patient can be actually becoming normotensive. So in this patient, like the most women become normoglycemic after pregnancy. When the gestation period is over, most of them can be normoglycemic. However, around 30 to 50% of those women can develop type 2 DM later in life. That is why gestational DM is one risk factor by way for type 2 DM. If they do have high sugar during gestation, the probability of having DM later in the life is high. That is, it accounts for 30 to 50%. Okay, then. So as I mentioned before, the insulin resistance in this patient is due to what? It's mainly due to hormonal changes, as I mentioned, and usually resolves on its own after giving birth. So what really causes, or what kind of hormonal changes really cause insulin resistance? So during the gestation period, the hormone that raises blood glucose or break down insulin usually overrides those that lower the blood glucose level. So like the placenta can actually even produce a hormone that actually degrades insulin, and also even there are several hormones that will be raised, and this ultimately increases insulin. So what are the changes, or what are the hormonal changes during pregnancy? The growth hormone, the cortisol level, estrogen and progesterone level, the human placental lactogen, those are the hormones that usually very elevated and causes insulin or high sugar level. However, if you look at the human placental lactogen, it is the hormone produced in the placenta that helps us break down of fat from the mother to provide energy for the fetus. So as a result, the sugar level can be elevated. And also there is placental insulinase. So this is a hormone that inactivates the action of insulin. So generally, like the hormone that raises the sugar level and breaks down the insulin usually overrides during gestation. So that is why gestational DM is really a common condition, and especially in the third trimester of pregnancy. So what will happen if the sugar is not treated? If the gestational DM is not treated, it can hurt your baby. Remember, insulin does not cross the placenta. That is why when a patient is having gestational DM, mostly insulin is like the drug of choice. However, the glucose and other nutrients, they will pass the placental barrier. They can actually cross what? The placental barrier. So remember, like when the mother is having high sugar level, now the extra blood glucose goes through the placenta, giving the baby high blood glucose level. So like the mother is having high sugar, and that it crosses the placental barrier, and the baby is getting high sugar level. So this causes the baby pancreas to make extra insulin to get rid of the blood glucose level. So as a result, the pancreas of the baby will be activated and extra insulin will be produced. So since the baby is getting more of the energy than it needs to grow and develop, the extra energy is stored in the form of fat because of even insulin. Remember, when the baby is getting more energy, the baby will grow, and then ultimately the baby will produce more insulin. So that insulin will actually form a synthesis of lipid and stored in the form of fat. Then this leads to macrosomia or fat baby. So this is the most common problem that you will see. This is how the baby look like, by the way, if the sugar is not controlled during gestational DM. We call it macrosomia, like the fat baby, and mostly the weight of the baby at birth is usually around 4 kg, around 4 kg or above 4 kg. We call it macrosomia or fat baby. Then, because the extra insulin made by the baby pancreas, the newborn may have very low blood glucose level at birth because they're actually producing more of insulin. And the patient will have, or the child will have at risk of breathing problem, as well as even the babies with excess insulin become children who are at risk for obesity and adults who are at risk of type 2 DM. Because of that reason, by the way, this condition, like the baby becomes actually grow later after birth, or like obesity, and risk of type 2 DM is very, very high as a result of gestational DM. So this is the major complication. But you can actually even imagine if the baby is above 4 kg, if the baby is above 4 kg, normal delivery is unlikely. So this even leads to cesarean section. So the mother will not deliver a kg or above 4 kg. In fact, one of the indications of cesarean section is actually like large weight of the baby. Because of that, the mother is supposed to do and cannot do under normal delivery. Okay, this is all about the type of gestational DM. I think in the next few minutes, because I think I've already mentioned about this one, So let us see. In the next few minutes, let us see like the video I mentioned at the beginning of the session, because I've already given you introductory session. Today is introductory session. So in the next few minutes, like the breakout session, it is not a real breakout session. Let us watch the video together. Any questions so far? Any question? So did you learn something?
Yes.
Okay, any question?
I have a question.
Okay.
Is glycated hemoglobin a test to detect diabetes mellitus or?
Yes, at the moment, before that, by then they usually use the fasting blood sugar level and the random sugar level and the IGTT. But now even glycated hemoglobin is like part of the diagnostic test. We'll see that, by the way. It's already indicated in the latest guideline of ADA, and it's just one of the tests for diabetes mellitus. Good observation. Okay, fine. So let us see that video together, which was obtained from osmosis.org.
Learning medicine is hard work. Osmosis makes it easy. It takes your lectures and notes to create a personalized study plan with exclusive videos, practice questions, and flashcards, and so much more. Try it free today. In diabetes mellitus, your body has trouble moving glucose, which is a type of sugar, from your blood into your cells. This leads to high levels of glucose in your blood and not enough of it in your cells. And remember that your cells need glucose as a source of energy. So not letting the glucose enter means that the cells starve for energy, despite having glucose right on their doorstep. In general, the body controls how much glucose is in the blood relative to how much gets into the cells with two hormones, insulin and glucagon. Insulin is used to reduce blood glucose levels, and glucagon is used to increase blood glucose levels. Both of these hormones are produced by clusters of cells in the pancreas called islets of Langerhans. Insulin is secreted by beta cells in the center of these islets, and glucagon is secreted by alpha cells in the periphery of the islets. Insulin reduces the amount of glucose in the blood by binding to insulin receptors embedded in the cell membrane of various insulin-responsive tissues, like muscle cells and adipose tissue. When activated, the insulin receptors cause vesicles containing glucose transporter that are inside the cell to fuse with the cell membrane, allowing glucose to be transported into the cell. Glucagon does exactly the opposite. It raises the blood glucose levels by getting the liver to generate new molecules of glucose from other molecules, and also break down glycogen into glucose so that it can all get dumped into the blood. Diabetes mellitus is diagnosed when blood glucose levels get too high, and this is seen among 10% of the world population. There are two types of diabetes, type 1 and type 2, and the main difference between them is the underlying mechanism that causes the blood glucose levels to rise. About 10% of people with diabetes have type 1, and the remaining 90% of people with diabetes have type 2. Let's start with type 1 diabetes mellitus, sometimes just called type 1 diabetes. In this situation, the body doesn't make enough insulin. The reason this happens is that in type 1 diabetes, there's a type 4 hypersensitivity response, or a cell-mediated immune response, where a person's own T cells attack the pancreas. As a quick review, remember that the immune system has T cells that react to all sorts of antigens, which are usually small peptides, polysaccharides, or lipids, and that some of these antigens are part of our own body's cells. It doesn't make sense to allow T cells that will attack our own cells to hang around, and so there's this process to eliminate them called self-tolerance. In type 1 diabetes, there's a genetic abnormality that causes a loss of self-tolerance among T cells that specifically target the beta cell antigens. Losing self-tolerance means that these T cells are allowed to recruit other immune cells and coordinate an attack on these beta cells. Losing beta cells means less insulin, and less insulin means that glucose piles up in the blood, because it can't enter the body's cells. One really important group of genes involved in regulation of the immune response is the human leukocyte antigen system, or HLA system. Even though it's called a system, it's basically this group of genes on chromosome 6 that encode the major histocompatibility complex, or MHC, which is a protein that's extremely important in helping the immune system recognize foreign molecules, as well as maintaining self-tolerance. MHC is like the serving platter that antigens are presented to the immune cells on. Interestingly, people with type 1 diabetes often have specific HLA genes in common with each other. One called HLA-DR3 and another called HLA-DR4. But this is just a genetic clue, right? Because not everyone with HLA-DR3 and HLA-DR4 develops diabetes. In diabetes mellitus type 1, destruction of beta cells usually starts early in life, but sometimes up to 90% of the beta cells are destroyed before symptoms crop up. 4 clinical symptoms of uncontrolled diabetes that all sound similar are polyphagia, glycosuria, polyuria, and polydipsia. Let's go through them one by one. Even though there's a lot of glucose in the blood, it cannot get into the cells, which leaves cells starved for energy. So in response, adipose tissue starts breaking down fat, called lipolysis, and muscle tissue starts breaking down proteins, both of which result in weight loss for someone with uncontrolled diabetes. This catabolic state leaves people feeling hungry, also known as polyphagia. Phasia means eating, and poly means a lot. Now, with high glucose levels, that means that when blood gets filtered through the kidneys, some of it starts to spill into the urine, called glycosuria. Glycose refers to glucose, and urea, the urine. Since glucose is osmotically active, water tends to follow it, resulting in an increase in urination, or polyuria. Poly again refers to a lot, and urea again refers to urine. Finally, because there's so much urination, people with uncontrolled diabetes become dehydrated and thirsty, or polydipsia. Poly means a lot, and dipsia means thirst. Even though people with diabetes are not able to produce their own insulin, they can still respond to insulin. So treatment involves lifelong insulin therapy to regulate their blood glucose levels and basically enable their cells to use glucose. One really serious complication with type 1 diabetes is called diabetic ketoacidosis, or DKA. To understand it, let's go back to the process of lipolysis, where fat is broken down into free fatty acids. After that happens, the liver turns the fatty acids into ketone bodies, like acetoacetic acid and beta-hydroxybutyric acid. Acetoacetic acid is a keto acid because it has a ketone group and a carboxylic acid group. Beta-hydroxybutyric acid, on the other hand, even though it's still one of the ketone bodies, isn't technically a keto acid, since its ketone group has been reduced to a hydroxyl group. These ketone bodies are important because they can be used by cells for energy, but they also increase the acidity of the blood, which is why it's called ketoacidosis. And the blood becoming really acidic can have major effects throughout the body. Individuals can develop Kussmaul respiration, which is a deep and labored breathing as the body tries to move carbon dioxide out of the blood, in an effort to reduce its acidity. Cells also have a transporter that exchanges hydrogen ions, or protons, for potassium. When the blood gets acidic, it's by definition loaded with protons that get sent into cells while potassium gets sent into the fluid outside cells. Another thing to keep in mind is that in addition to helping glucose enter cells, insulin stimulates the sodium-potassium ATPases, which help potassium get into the cells. And so without insulin, more potassium stays in the fluid outside cells. Both of these mechanisms lead to increased potassium in the fluid outside cells, which quickly makes it into the blood and causes hyperkalemia. The potassium is then excreted. So over time, even though the blood potassium levels remain high, overall stores of potassium in the body, which include potassium inside cells, starts to run low. Individuals will also have a high anion gap, which reflects a large difference in the unmeasured negative and positive ions in the serum, largely due to the buildup of keto acids. Diabetic ketoacidosis can happen even in people who've already been diagnosed with diabetes and currently have some sort of insulin therapy. In states of stress, like an infection, the body releases epinephrine, which in turn stimulates the release of glucagon. Too much glucagon can tip the delicate hormonal balance of glucagon and insulin in favor of elevating blood sugars and can lead to a cascade of events we just described: increased glucose in the blood, loss of glucose in the urine, loss of water, dehydration, and in parallel, a need for alternative energy, generation of ketone bodies, and ketoacidosis. Interestingly, both ketone bodies break down into acetone and escape as a gas by getting breathed out the lungs, which gives a sweet, fruity smell to a person's breath. In general, though, that's the only sweet thing about this illness, which also causes nausea, vomiting, and if severe, mental status changes and acute cerebral edema. Treatment of a DKA episode involves giving plenty of fluids, which helps with dehydration, insulin, which helps lower blood glucose levels, and replacement of electrolytes, like potassium, all of which help to reverse the acidosis. Now let's switch gears and talk about type 2 diabetes, which is where the body makes insulin, but the tissues don't respond as well to it.
My philosophy was always very simple. We buy the best ingredients and then...
The exact reason why cells don't respond isn't fully understood. Essentially, the body's providing the normal amount of insulin, but the cells don't move their glucose transporters to their membrane in response, which remember is needed for the glucose to get into the cells. These cells therefore have insulin resistance. Some risk factors for insulin resistance are obesity, lack of exercise, and hypertension. and the exact mechanisms are still being explored. For example, an excess of adipose tissue, or fat, is thought to cause the release of free fatty acids and so-called adipokines, which are signaling molecules that can cause inflammation, which seems related to insulin resistance. However, many people that are obese are not diabetic, so genetic factors probably play a major role as well. We see this when we look at twin studies as well, where having a twin with type 2 diabetes increases the risk of developing type 2 diabetes, completely independently of other environmental risk factors. In type 2 diabetes, since tissues don't respond as well to normal levels of insulin, the body ends up producing more insulin in order to get the same effect and move glucose out of the blood. They do this through beta cell hyperplasia, an increased number of beta cells, and beta cell hypertrophy, where they actually grow in size, all in this attempt to pump out more insulin. This works for a while, and by keeping insulin levels higher than normal, blood glucose levels can be kept normal, called normoglycemia. Now, along with insulin, beta cells also secrete islet amyloid polypeptide, or amylin. So while beta cells are cranking out insulin, they also secrete an increased amount of amylin. Over time, amylin builds up and aggregates in the islets. This beta cell compensation, though, is not sustainable. And over time, those maxed out beta cells get exhausted, and they become dysfunctional, and undergo hypertrophy, and get smaller, as well as hypoplasia and die off. As beta cells are lost and insulin levels decrease, glucose levels in the blood start to increase, and patients develop hyperglycemia, which leads to similar clinical signs that we mentioned before, like polyphagia, glycosuria, polyuria, and polydipsia. But unlike type 1 diabetes, there's generally some circulating insulin in type 2 diabetes from the beta cells that are trying to compensate for the insulin resistance. This means that the insulin-glucagon balance is such that diabetic ketoacidosis does not usually develop. Having said that, a complication called hyperosmolar hyperglycemic state, or HHS, is much more common in type 2 diabetes than type 1 diabetes. And it causes increased plasma osmolarity due to extreme dehydration and concentration of the blood. To help understand this, remember that glucose is a polar molecule that cannot passively diffuse across cell membranes, which means that it acts as a solute. So when levels of glucose are super high in the blood, meaning it's a hyperosmolar state, water starts to leave the body's cells and enter the blood vessels, leaving the cells relatively dry and shriveled, rather than plump and juicy. Blood vessels that are full of water lead to increased urination and total body dehydration. And this is a very serious situation, because the dehydration of the body's cells, and in particular the brain, can cause a number of symptoms, including mental status changes. In HHS, you can sometimes see mild ketonemia and acidosis, but not to the extent that it's seen in DKA. And in DKA, you can see some hyperosmolarity, so there's definitely overlap between these two syndromes. Besides type 1 and type 2 diabetes, there are also a couple other subtypes of diabetes mellitus. Gestational diabetes is when pregnant women have increased blood glucose, which is particularly during the third trimester. Although ultimately unknown, the cause is thought to be related to pregnancy hormones that interfere with insulin's action on insulin receptors. Also, sometimes people can develop drug-induced diabetes, which is where medications have side effects that tend to increase blood glucose levels. The mechanism for both of these is thought to be related to insulin resistance, like type 2 diabetes, rather than an autoimmune destruction process like in type 1 diabetes. Diagnosing type 1 or type 2 diabetes is done by getting a sense for how much glucose is floating around in the blood, and has specific standards that the World Health Organization uses. Very commonly, a fasting glucose test is taken where the person doesn't eat or drink, except water, that's okay, for a total of 8 hours, and then has their blood tested for glucose levels. Levels of 100 milligrams per deciliter to 125 milligrams per deciliter indicates prediabetes, and 126 milligrams per deciliter or higher indicates diabetes. A non-fasting or random glucose test can be done at any time, with 200 milligrams per deciliter or higher being a red flag for diabetes. Another test is called an oral glucose tolerance test, where a person is given glucose, and then blood samples are taken at time intervals to figure out how well it's being cleared from the blood, the most important interval being 2 hours later. Levels of 140 milligrams per deciliter to 199 milligrams per deciliter indicate prediabetes, and 200 or above indicates diabetes. Another thing to know is that when blood glucose levels get high, the glucose can also stick to proteins that are floating around in the blood or in cells. So that brings us to another type of test that can be done, which is the HbA1c test, which tests for the proportion of hemoglobin in red blood cells that has glucose stuck to it, called glycated hemoglobin. HbA1c levels of 5.7% to 6.4% indicate prediabetes, and 6.5% or higher indicates diabetes. This proportion of glycated hemoglobin doesn't change day to day, so it gives a sense for whether the blood glucose levels have been high over the past 2 to 3 months. Finally, we have the C-peptide test, which tests for byproducts of insulin production. If the level of C-peptide is low or absent, it means the pancreas is no longer producing enough insulin, and the glucose cannot enter the cells. For type 1 diabetes, insulin is the only treatment option. For type 2 diabetes, on the other hand, lifestyle changes like weight loss and exercise, along with a healthy diet and oral anti-diabetic medication, like metformin and several other classes, can sometimes be enough to reverse some of that insulin resistance and keep blood sugar levels in check. However, if oral anti-diabetic medications fail, type 2 diabetes can also be treated with insulin. Something to bear in mind is that insulin treatment comes with a risk of hypoglycemia, especially if insulin is taken without a meal. Symptoms of hypoglycemia can be mild, like weakness, hunger, and shaking, but they can progress to a loss of consciousness and seizures in severe cases. In mild cases, drinking juices or eating candy or sugar might be enough to bring blood sugar up, but in severe cases, intravenous glucose should be given as soon as possible. The FDA has also recently approved intranasal glucagon as a treatment for severe hypoglycemia. Alright, now over time, high glucose levels can cause damage to tiny blood vessels, called the microvasculature. In arterioles, a process called hyaline arteriolosclerosis is where the walls of the arterioles develop hyaline deposits, which are deposits of proteins, and these make them hard and inflexible. In capillaries, the basement membrane can thicken and make it difficult for oxygen to easily move from the capillary to the tissues, causing hypoxia. One of the most significant effects is that diabetes increases the risk of medium and large arterial wall damage, and subsequent atherosclerosis, which can lead to heart attacks and strokes, which are major causes of morbidity and mortality for patients with diabetes. In the eyes, diabetes can lead to retinopathy, and evidence of that can be seen on a fundoscopic exam that shows cotton wool spots or flare hemorrhages, and can eventually cause blindness. In the kidneys, the afferent and efferent arterioles, as well as the glomerulus itself, can get damaged, which can lead to a nephrotic syndrome that slowly diminishes the kidney's ability to filter blood over time, and can ultimately lead to dialysis. Diabetes can also affect the function of nerves, causing symptoms like a decrease in sensation in the toes and fingers, sometimes called the stocking glove distribution, as well as causes the autonomic nervous system to malfunction. And that system controls a number of body functions, everything from sweating to passing gas. Finally, both the poor blood supply and nerve damage can lead to ulcers, typically on the feet, that don't heal quickly and can get pretty severe and need to be amputated. These are some of the complications of uncontrolled diabetes, which is why it's important to diagnose and control diabetes through a healthy lifestyle, medications to reduce insulin resistance, and even insulin therapy if beta cells have been exhausted. While type 1 diabetes cannot be prevented, type 2 diabetes can. In fact, many people with diabetes can control their blood sugar levels really effectively and live a full and active life without any of the complications. Thanks for watching. If you're interested in a deeper dive on this topic,
okay, so this is what I have for today. Any questions?